Hello and warm good morning to all of you. Today is the day 2, that is 20th February 2022 of CardioCon 2022. I am Dr. Mithlesh Kulkarni, Assistant Professor Cardiology of UN Mehta Institute at Ahmedabad. First of all, I would like to thank Dr. Kamal Sharma sir for giving me this wonderful opportunity to speak on this topic. Coming straight forward to the topic is my case is a 55-year-old male with AICD implanted 2 years back has come to us in storm with 12 shocks in last 24 hours. So my talk will be on the approach, the management, including the diagnosis and the treatment of such a patient. So, first of all, I would like to stress on the point that why is it important to discuss such a topic? Because post AICD shocks have got an increased mortality, therefore important to diagnose and treat the precipitant of shocks. Further evaluation will require that if a patient is having AICD shocks, then we need to do the reassessment of heart failure, that whether the device therapy is appropriate or not. Does it require a step up? And is there any increase in the ischemia burden? So basically, this chart has been taken from the Brunwald textbook, the latest edition. And we will discuss this differential diagnosis of ICD shocks. So what we'll do is whenever a patient comes to us with a history of post AICD VT storm, first we analyze the data and the clinical data, the AICD data and the clinical data, and we classify them whether it is due to tachyarrhythmia or there is no tachyarrhythmia, that is oversensing. If there is tachyarrhythmia, whether it is due to SVT or that is inappropriate detection, or it is due to VTVF, that is appropriate detection. And again, if it is due to VTVF, then we have to say whether it is a avoidable shock in which the ATP is preferred, and whether it is a necessary shock in which VF or ATP will be unsuccessful. And again, coming if it is not a tachyarrhythmia, that is it is due to oversensing, then it can be due to intracardiac signals or extracardiac signals. So directly coming to the management of AICD shocks, so how to manage a patient who is post AICD and presenting with shocks. We need to, the basic goal is to reduce the number of shocks, which will require the strategic programming, the patient alert, and the remote monitoring. And once the shock occurs, we also have to look into the history of the patient, that what were the symptoms at the time of shock. Was he having some sort of palpitations, VT, MI, the radiology for the lead position, or if is there any form of lung pathology like pneumothorax disturbing the I would say the lead placement. And the ICD diagnostic, obviously, whether the sensing and the shock was proper or not. So we see that in AICD, there are two types of AICD, as we all know, whether it is placed transvenous or subcutaneous. The shocks can be due to oversensing, and T wave oversensing was once a common cause of inappropriate shocks in transvenous ICD. But now they have reduced due to programming options. But in subcutaneous ICD, even today, the most common cause of shock is T wave oversensing. So as we said that in the differential diagnosis of the patient with post AICD shocks, he can have either of the above, like we discussed. Either he can have a tachyarrhythmia or there will be no tachyarrhythmia. And as I said, in tachyarrhythmia, either it can be a SVT or it can be a VTVF. So we'll go stepwise how to manage the each entity of a patient having shocks post AICD insertion. So a patient presenting with SVT, that is supraventricular tachyarrhythmia. So it can be done by reprogramming. We can do the reprogramming of the device using the SVT VT discriminators, and we can also go ahead with the medical line of therapy. So for a patient who is having shocks due to SVT, the drugs which can be used are: first is the beta blocker, second are the anti-arrhythmic drugs, and in some cases we can also go ahead with the EP study and the radio frequency ablation. So, coming to the patient who has presented to us in emergency, we all know that it is a form of medical emergency. We have to determine the cause, we have to treat the cause because this is life threatening. The VTVF detection may be disabled by a programmer or a magnet. So this is important that it is a medical emergency. Rule out the cause, treat the cause, and if not, then we have to disable it by a programmer or by a magnet. So what can be actual causes of repetitive shocks? Like a patient having ICD and coming to us with repetitive shocks. Either it has to be multiple unsuccessful shocks for a single episode, or it can be due to recurrent VTVF after successful shock termination. So we have to know which of it is. So again, coming to the like multiple shocks for AF or SVT with rapid rates, the treatment will be treatment of the underlying arrhythmia, correction of the device malfunction if there is any, the reprogramming of the detection criteria, the detection and the VT criteria, or the disability of the detection. And I would like to say that we have to hospitalize such patients because we need to monitor them, and we see whether the parameters of ICD are okay or not. Coming to the next slide, a patient presenting with us with VT storm, like the case which we are discussing, a patient presenting to us with VT storm, as I said, first we have to point out the cause for the precipitating event. The acute event can be in the form of 5 of the below. First is acute ischemia, patient with post AICD having acute ischemia. Second, it can be exacerbation of heart failure. This exacerbation of heart failure itself can be because of some electrolyte imbalance or some sort of arrhythmia. Next is the metabolic abnormalities. The fourth reason for the fourth cause of precipitating is the drug proarrhythmias, and next is the non-compliance. So if we see that in a patient there is no reversible cause, that is the precipitating event cannot be searched, then we have to start on drug therapy like the beta blockers. We go to, if the patient is not able to revert on beta blockers, then we shift to ablation, and last will be the neuraxial interventions. In this, I would like to also discuss about the unsuccessful ICD shocks. We have to determine a patient coming post AICD shocks. If the ICD shocks are unsuccessful, so what will be the causes of unsuccessful ICD shocks? These can be grouped into 3 major headings. First heading is a successful termination of VTVF, which is misclassified by the ICD. The VTVF recurs before the device determines the VTVF episode as terminated. Failure to terminate the SVT post-block rhythm is SPT. There can also be patient-related factors which lead to ICD shocks, like metabolic, like the hyperkalemia, ischemia, progression of heart failure, some antiarrhythmic drugs like the amiodarone, specifically the type C anti-1C antiarrhythmic class of drugs, some pleural or pericardial effusion. And third heading for unsuccessful ICD shocks will be device system related reasons like the insufficient program shock strength, battery depletion, failure of generator component or lead, device lead connection problem, lead dislodgement, and delayed detection resulting in prolonged VTVF that increases required shock strength. So we have to do a patient coming to us with the VT storm. We have to do the EGM analysis. The whether the shock truly failed to terminate the VTVF or the ICD misclassified effective therapy as ineffective. So we have to analyze whether the shock did not terminate the VTVF or it was misclassified. So shocks in a chronic ICD system may fail to terminate the true VTVF because of the following reasons. There can be patient-related causes, ICD system-related causes like the excessive detection, lead failure, connection failure, out-of-range voltage impedance. In the absence of diagnosis, ultimately the defibrillation testing should be performed. At the end, I would like to present this small flowchart in the form of summary in the way how to treat a patient presenting to us with multiple VT shocks in a patient who has undergone ICD. So a patient coming to us with more than one shock in 24 hours, if he is not having any cardiac symptoms, send the remote transmission, analyze the EGM data, necessary shock was given, then no further action is required. If we found that it was an unnecessary shock, then we'll have to do the troubleshooting. If we find that the patient is having some sort of cardiac symptoms, then we need evaluation, that we send the remote transmission. The patient requires urgent evaluation, consider for emergency medical service admission and hospitalization. After hospitalization, we'll be analyzing the EGM data. After that, if we find that there is some form of avoidable or inappropriate shocks, then we again do the troubleshooting. And if we find that it is if it is necessary shocks, we do the address triggers, we use the drugs including beta blockers, or we go to the EP study, ablation, anesthesia, or ultimately we do the autonomic modulation. Thank you so much. I hope this talk was useful. And again, I would like to thank Dr. Kamal Sharma sir for giving me this wonderful opportunity of presenting my talk. Thank you.